Hi, I'm Angus Ramsay, and I'm delighted to be presenting our evaluation of pre-hospital video triage for suspected stroke patients at the HSR UK conference. First, a little background to our evaluation. Evidence suggests that stroke patients who are treated in a specialist stroke unit are more likely to get the right care at the right time. This contributes to better long-term outcomes, for instance in terms of mortality and functional independence. Most patients who have a stroke are transferred from the community to hospital by ambulance. Ambulance clinicians use screening tools to identify whether someone is having a stroke. A common example of this is the Face-Arm-Speech Screening Test, or FAST for short. However, such tools can be over-inclusive. While they identify most stroke patients, they also identify lots of people who turn out not to have had a stroke. This means that many non-stroke patients often get taken to stroke units. Consequently, many may not get the right care as soon as they should, for instance because they've bypassed their local hospital to get to a stroke unit. And it also means stroke teams have less time to devote to stroke patients, because they are also providing care to a number of non-stroke patients. Further, at the beginning of the COVID-19 pandemic, concerns arose about whether stroke patients were being taken reliably to stroke units. There were also concerns that non-stroke patients were making unnecessary journeys to stroke units and either catching or spreading COVID-19. In response to these concerns, in the spring of 2020, ambulance and stroke clinicians in North Central London and East Kent introduced pre-hospital video triage for suspected stroke patients. These services let ambulance and stroke clinicians communicate using iPads and FaceTime, so that stroke clinicians could assess potential stroke patients while they were still on site. It was hoped that this would result in patients being more likely to be taken to the right service, reduce unnecessary pressure on stroke and other services, and reduce risks of unnecessary spread of COVID-19. To investigate these new services, we conducted a rapid service evaluation. We were interested to learn about the evidence base for pre-hospital video triage for stroke, the perceived acceptability, usability and safety of pre-hospital video triage in North Central London and East Kent, whether these services supported appropriate, safe and timely conveyance and treatment of stroke patients, which factors played a part in implementation and impact, and which aspects of the services should be retained long term. Here is our team. As you can see, we had a good mix of researchers, clinicians and patient representatives. Our project ran from July 2020 to September 2021. We needed a short extension because we had to pause data collection for roughly 3 months in early 2021. Our project was conducted as part of the Rapid Service Evaluation Team programme funded by NIHR. So, what did we do? Our rapid mixed method evaluation included 2 rapid literature reviews. We ran a qualitative analysis of the new pre-hospital triage services in North Central London and East Kent, drawing on interviews, observations and documents. We conducted a survey of over 200 ambulance clinicians in North Central London and East Kent, and we carried out quantitative analyses of local data on ambulance conveyance and national audit data on delivery of stroke clinical interventions. I'll now run through some of our key findings. At points, you may wish to pause the video in order to inspect the slide contents in detail. First, our literature review suggested that the evidence on pre-hospital video triage for stroke is limited but growing. The evidence we found suggested that such services can be usable and acceptable to staff, and that signal quality, training and interprofessional communication may play a part in this. However, our review also suggested that the bulk of evidence to date has been based on simulations or single-site pilots, and several important issues, including impact on patient outcomes and cost-effectiveness, are yet to be analysed in depth. Now, let's turn to our analyses of the North Central London and East Kent pilots. In the following slides, I've brought together some of the key findings from our survey and qualitative work. First, clinicians in both areas viewed pre-hospital triage as highly usable and acceptable. They preferred it to what had happened in the past and wanted it to continue. However, North Central London survey respondents seemed generally more positive than in East Kent. Video triage relied on stable network and audio-visual signal. Ambulance clinicians in both areas described workarounds for signal failures, commonly reverting to traditional conveyance decision-making processes. Ambulance clinicians described how pre-hospital video triage increased their confidence in their conveyance decisions. Specialist input from the stroke team provided a degree of reassurance. Stroke clinicians, while they were positive about the service, raised concerns about performing triage assessments alongside their everyday duties. This placed increased pressure on them. Most staff in both areas felt the services were safe. However, a proportion of ambulance clinicians in East Kent had some concerns about safety. These mostly focused on whether time spent conducting triage on site represented an unwarranted delay to patients receiving specialist hospital care. Local leads of the triage programmes were highly conscious of the potential safety risks of these systems. Therefore, they set in place a number of processes, including governance meetings and audits of what happened to patients not transferred to stroke units. These processes established that only a very small number of stroke patients were not being transferred to stroke services, and the learning from these activities was used to support ongoing adaptations and improvements to the process and pathway. This was seen as an important way to reassure staff and the wider system about the safety of these new services. Our analysis of implementation was guided by Nolte's framework for understanding implementation of complex innovations in healthcare settings. Implementation was influenced by several factors interacting across different organisational levels. For instance, COVID-19 created a strong impetus for change. Locally, this prompted adaptation of management and governance processes to be more open to innovation. Proposals for change were processed more quickly. The pre-hospital triage innovation fitted well with professional values, especially in terms of the prioritisation of delivering appropriate high-quality care. Also, the technology used, tablets and FaceTime, was already familiar to most users. Clinical leaders in local stroke and ambulance services engaged actively to develop and implement the new services, working across organisational boundaries both within and beyond their host organisation, and working closely with different professions. Training helped ambulance clinicians feel more confident with delivering pre-hospital video triage. They preferred active training approaches such as in-person or online run-throughs as employed in North Central London. Turning to our quantitative analyses, to understand impact on patient conveyance, we analysed local ambulance journey data for 1,400 journeys where pre-hospital video triage was used. We found that approximately 60% of suspected strokes in North Central London and 50% in East Kent were not transferred to a stroke unit. Local audits and our observations of meetings where these data were reviewed suggested that only a very small number of patients who were not transferred to stroke unit turned out to have actually had a stroke. Further, over 95% of patients, and all patients in East Kent, were transferred to hospital within recommended journey time thresholds. Next, we focused in on conveyance of stroke patients alone. National stroke audit data indicated no evidence of increased median time from stroke symptom onset to arrival at services. For example, this chart presents median time from symptom onset to arrival at a stroke unit. If we look at the orange bars on this chart, representing the North Central London Specialist Stroke Unit, and the green bars, covering the East Kent Specialist Stroke Units, we can see that there appear to be reductions in median time from onset to arrival at stroke unit following introduction of pre-hospital video triage. In contrast, the purple bars suggest little change over time at national level. Finally, we looked at delivery of stroke clinical interventions such as timely brain scan and clot-busting therapy if appropriate. We analysed stroke national audit data at team level for almost 140,000 stroke patients submitted from 2018 to 2020. We compared North Central London and East Kent relative to the rest of England to see whether relative performance changed over time. We found that following introduction of pre-hospital triage, the services in North Central London and East Kent either performed better than services elsewhere over time or showed no significant differences. However, some of the improvements may have been due to other service reorganisations that took place at the same time. So, what did we learn? Our literature reviews found a limited but growing evidence base on pre-hospital video triage for suspected stroke. We believe our evaluation of the pre-hospital triage services implemented in North Central London and East Kent adds to this evidence base in a number of ways. We found that these services were seen as usable, acceptable, and safe. Especially important to usability was the stability of network and audio-visual signals. Another important contributor to usability was training, which was important to giving ambulance staff confidence in the new services. We found that active training, whether online or in person, was preferred by ambulance clinicians. In terms of acceptability, stroke clinician workload was seen as a key risk, with implications for long-term sustainability of these services. To address safety concerns, governance processes were set in place to monitor how the triage services were working and to learn from any incidents. By drawing on Nolte's conceptual framework, we were able to make important additions to understanding of how services of this kind might be implemented. National and local context, including the COVID-19 pandemic and wider concerns about patient conveyance, were important drivers for change. Finally, collaborative clinical leadership and engaging implementation approaches, operating at different levels within and beyond host organisations, helped enable rapid approval and uptake of the new services. This evaluation was an exciting opportunity to study two similar services being implemented at the same time and develop helpful lessons for other healthcare services thinking about implementing services of this kind. However, there were several limitations to our work. We couldn't interview stroke and non-stroke patients and carers, and a range of other stakeholders, including nurses, managers, and the wider system governance. Our ambulance conveyance data had no historical or regional comparators, meaning we could not assess with confidence the impact of pre-hospital triage on conveyance times. The stroke national audit data that we analysed were aggregated at team level and did not capture a range of safety issues, which limited the extent to which we could assess the impact of pre-hospital video triage on quality and safety. Finally, our survey used a convenience sample. That is, while we targeted only people who had used the services, we had no control over which clinicians decided to take part. To address several of these limitations, I and my colleagues are excited to have recently begun a new research project funded by the NIHR Health and Social Care Delivery Research Programme. Photonic is a mixed method study and will run from 2021 to 2023, analysing implementation and impact of pre-hospital triage in North Central London, East Kent, Darrant Valley and Maidstone. We'll get perspectives from a wider range of stakeholders, including stroke and non-stroke patients and carers. We'll use patient-level data with national controls to understand the impact of pre-hospital triage on conveyance, care delivery, outcomes and value for money. And through this, we'll provide lessons for further implementation of pre-hospital video triage in stroke and other settings. Here is the reference for our final report, which will be published this summer. The NIHR First Look summary is already available from our project website. I'd like to acknowledge the people who gave their time and insights so generously. This evaluation could not have happened without them. And, as mentioned earlier, this evaluation was conducted through the NIHR Rapid Service Evaluation Team programme. Thank you for listening. I hope to see at least some of you in July to get your insights in person. In the meantime, please use these details if you would like to learn more about any aspect of our work on this important innovation or have any questions. Bye for now.